Good afternoon, everyone, and welcome. My name is Maria Morris Groves, and I have the pleasure of being the Director of Adolescent Women and Family Services at the State Office of Addiction Services and Support. On behalf of our office and the Partnership to End Addiction, welcome to the first of a three-part series of conversations with the experts, treatment of adolescents with substance use disorders and the use of medication. Today's presentation will be a dialogue between our own Dr. Marc Manseau, our Chief of Medical Services for our office, Dr. Marc Fishman, an addiction psychiatrist and a faculty member of behavioral science at Johns Hopkins, and Dr. Sharon Levy, the Director of Adolescent Substance Use and Addiction Programs and a professor of pediatrics at Harvard. Just a couple of housekeeping things before we begin. Once I finish, we will all be muted. If you have questions, please use the chat box. We're grateful that you're able to join us today. We are recording this for posting later for those that aren't able to join us. And we hope that you'll enjoy this conversation and join us for our next two conversations later in the month. Thank you. And Dr. Manseau, Dr. Levy, and Dr. Fishman, thank you very much for joining us today. And I'll turn it over to you.
Thank you so much, Maria. So I'm Marc Manseau. I'm the Chief Medical Officer for New York State OASAS, and I really have the pleasure today of having Dr. Fishman and Dr. Levy join me. Really, I mean, we're fortunate in New York State to be able to have been able to get two of the nation's experts truly on the topic of addiction and addiction medications for the adolescent and youth population to join us today, and to really set the stage for a series where we really hope people will be able to learn a lot about how to work with this population in general, but also specifically how to use medications to treat addiction in this population. We do know that this population is at great risk of adverse outcomes for addiction, and particularly opioid use disorder, but all addiction really, and that medications and evidence-based treatments are vastly underutilized for this population. And so, I think there's been a lot of focus, rightfully so, on opioid use disorder, and this series will focus on opioid use disorder because opioid use disorder and opioids are killing so many people, including young people. But I also hope we're going to have a chance to talk about other substances and substance use disorders that can affect this population and some helpful strategies for those as well. So welcome, and I thank you for being here. So I think I'm just going to launch right into the questions that I had for both of you, and I'll give you both a chance to respond to each question. So the first question that I have for both of you is, what is the role of medical providers in treating adolescents and youth with alcohol use disorder, tobacco use disorder, opioid use disorder, and other substance use disorders?
Sharon?
I don't know who wants to begin.
Well,
Dr. Levy? Yeah.
Sure, I'm happy to take a stab at that one first. And thank you for the question, because I think it's one that we really don't ask enough and we should be asking more. So over the past 20, 25 years, there's been this enormous push to do what we call SBIRT, which is screening, brief intervention, referral to treatment. And that's in recognition of how common substance use problems and disorders are through the lifespan, starting in youth and continuing through the lifespan. How problematic they are in terms of health, and how we really can treat them in a variety of medical settings. So mostly SBIRT has focused on these brief interventions, which are largely counseling, right? So it's about, people will tell you brief intervention is about doing a motivational intervention or, doing some motivational interviewing. And I think the SBIRT movement has been really important in introducing the idea that we need to treat substance use disorders wherever we find them. It has really entrenched that idea across systems. And so now we're seeing it in primary care practices, in hospitals, in schools, in treatment centers, and really all of that has been wonderful. Now it's time that we think more broadly about what really brief interventions are. So there's definitely a component that's going to include some counseling, some advice, but particularly when it comes to shorter medical appointments, I think that there are a host of other things that we could do that are very typically in a physician's wheelhouse. And those include things like prescribing medications to prevent cravings, or identifying withdrawal symptoms if they're present and treating those symptomatically if we need to. It's things like drug testing, which can be useful in certain situations, particularly around adolescents who are trying to make behavior change and really helping to monitor them. And it's also about, it's about advice giving and education and some counseling as well. So I think it's really all of those things. And to date, I think the focus has largely been on counseling, almost to the exclusion of these other activities. So thank you for pulling this together to really remind us there are all these other things that we can be doing.
I totally echo what Dr. Levy said. I think that historically there has been a very unfortunate divide between the House of Medicine, the role of physicians and other healthcare providers, and the other health and advice-giving professions that have traditionally had their emphasis in addressing, assessing, and intervening and treating substance use disorders, counseling, therapists, specialty substance use programs, and the like. But I think that that's not a helpful divide, and anything we can do to bring those communities together to synergize and improve our ability to reach young people is a step in the right direction. And I think it goes in two major categories. One is thinking about where physicians are already encountering young people, so that it's noticing that young people in primary care, in family practice, in pediatrics, in the hospital, in psychiatric settings, in the psychiatric hospital, in the psychiatric outpatient office, where youth-serving physicians are already encountering young people who, whether they know it or not, have large prevalences of substance use disorders. Those physicians should wake up and smell the coffee and do SBIRT and do other kinds of things to engage with young people with all the tools in their tool chest, whether it's SBIRT, whether it's counseling, whether it's medication. So all the things that Dr. Levy said. And I think there are lots of good examples, which I'm sure we'll talk about in some greater detail, about paradigms and techniques and recipes for how to get that done. But not wait for young people to have to be so ill to be treatment seeking in specialty SUD settings. Certainly that's important, but if there are upstream kinds of touch points where they are already encountering doctors, then we need to activate those touch points. The other place where I think the medical community needs to wise up about intervening with young people is in the specialty SUD sector, and especially in those youth-serving adolescent or young adult specialty SUD treatment programs. Unfortunately, there haven't been enough doctors around. There hasn't been enough integration of medical activity. And so that's an opportunity for physicians, whether they are generalists or addiction medicine specialists or psychiatrists or any of the above, to become more active, both in terms of specific medical roles, assessing, treating with medications, but also just in terms of the general leadership that the House of Medicine brings to any healthcare setting to try to coordinate care, to try to think of the broader picture, to try to put SUDs in the context of all the other risk behaviors and chronic remitting relapsing illnesses that we find it important, and as you said, Dr. Levy, in our wheelhouse to treat. Add this to the list. So what she said.
And actually, just one other thought to really consolidate what Dr. Fishman said. I think by analogy, we can see that thinking about counseling or medications is a really false dichotomy. If yes. I said to anybody in this audience, what's the treatment for type 1 diabetes? Is it diet or is it medication? Is it insulin? Everybody would recognize that, no, it's both, right? We absolutely need to do both. You wouldn't just want one or the other. And this is exactly the same thing. And it's true for almost every chronic condition that we take care of, right? Is, for hypertension, or for, for almost anything that you can think of, it's the pairing of the two, not one or the other.
Yep.
Thanks so much. Yeah, so I'm hearing a very strong role for medical providers and physicians in addressing substance use disorders in adolescents and youth, which goes well beyond the sort of identifying the problem and referring to treatment, both outside and inside the specialty addiction treatment system. I wanted to follow up specifically on the idea of medications to treat particularly opioid use disorder, but also alcohol use disorder and tobacco use disorder and nicotine dependence in this population. I'm wondering, there tends to be a lot of questions, maybe I'll even call it confusion to some degree, on whether medications are appropriate and evidence-based within this population. And I'm just wondering if you and we're going to have more time in parts 2 and 3 of this series to really delve in a little bit more into the evidence base. But I'm just wondering if you could both touch upon that, particularly for opioid use disorder, but I'm interested in the other two as well.
Yeah, another great question. And hopefully we'll be able to take like the big question off the table, because I think that there is consensus amongst physicians, amongst governmental agencies, amongst the American Academy of Pediatrics and other organizations that really says that medication treatment for opioid use disorder saves lives. And that's true in youth as it is in adults. As always, there's been less formal study of these treatments in youth than there have been in adults, but there hasn't been none. There have been a number of studies that have been completed that have all shown that medication treatment is better than placebo, better than clonidine, better than some of the other treatments that we use to manage just the withdrawal symptoms. So I think that there's really no question that it's the standard of care and should be the standard of care for adolescents with opioid use disorder. The same is true for alcohol and tobacco use disorder, nicotine use disorder. That the evidence base is less, but we have every reason to believe that medications are helpful in these disorders, and I would consider them the standard of care for those disorders, as well as I believe most people, experts in the field, would agree.
I just want to slow down and underscore and reiterate what Dr. Levy just said about this concept of the standard of care. Medications for opioid use disorder, or MOUD, as is the current kind of fashionable jargon, or it used to be MAT, or medications for relapse prevention, whatever you want to call them. Medications for opioid use disorder, including in adolescents and young adults, are the standard of care. You can't be any more plain than that. To not use them for young people with opioid addiction is to miss the opportunity to save lives, to alter the course of a deadly, potentially chronically remitting and relapsing disease, and makes no sense. Now, I get the historical skepticism. We want to be careful. We want to be cautious in a pediatric population. You're going to give what to whom? And of course, we want to think carefully about that. But there is a very sizable and growing evidence base for efficacy and effectiveness. There is consensus among clinical experts, as Dr. Levy said. And the other good news is that there is no signal so far for any additional safety risk conferred by age or developmental stage. Of course, all medicines can have side effects, even Tylenol, including buprenorphine and naltrexone and the medicines that we're going to talk about, but it isn't more harmful, it isn't more fraught with side effects or peril because of age. So these are relatively safe, very effective, life-saving medicines. Again, the standard of care. And there's no reason to suspect a fail first standard should apply. So in some considerations, people have wondered, well, for young people, shouldn't we give them an opportunity to have treatment without medicines first? And then if they don't do well, okay, second line, let's use medicines. No, these are first line. There is no evidence to suspect that a fail first standard is appropriate. And besides, think about what fail first means. Fail first for opioid use disorder can be a bad day, right? We don't want to have to demonstrate through a fatal overdose risk that we wish we should have used the most effective standard of care treatment that we have.
Great, thank you for that. So I was wondering, sort of taking one disorder for which we have FDA-approved medication options at a time, starting with opioid use disorder. Do either of you have any key tips or clinical pearls that you'd like to share related to the use of medications for youth and adolescents with opioid use disorder?
Would you like to take that one first, Dr. Fishman?
I apologize. I was just reading the chat room and was going to respond to a question. Ask your question again.
Yeah.
My apologies.
So thanks for mentioning the chat room. I neglected to say very clearly at the beginning that, and it seems like people are already doing this, so it's great. Please put any questions you have in the chat room into the chat, type them into the chat, and I'll be looking at it and monitoring it, and we'll save the questions, responding to questions until the end. But Dr. Fishman, if you would like to respond to the one question you saw now, I mean, of course, feel free.
I do, because it's so critical to the conversation. The question is, well, why assume that medicines for OUD, buprenorphine, for example, are standard of care if youth haven't had the duration of exposure or the duration and evolution of disease process to cause the same kind of enduring and severe brain changes that might have happened with more road miles for older people? Well, that might be the case, that the duration is not as long, the consequences have not been as long, that whatever brain toxicity accrues may not be as much, but it doesn't mean that it isn't there and it isn't bad enough. Think, for example, when we think of a definition and how we assess for opioid addiction, we look for, at least as one marker, physiological dependence with frequent, perhaps daily use, and the presence of withdrawal. And for sure, young people with those features of opioid addiction can't be said not to have very significant brain changes, for which buprenorphine would, in fact, be totally appropriate. But this is not to say that we would have a threshold. We have no ability to see on an MRI, to detect in a lab test, to peer into the eyes of a young person and see the brain changes, but we know them clinically because of the markers of severity. Use the DSM checklist, use other criteria, but when opioid addiction is moderate to severe, again, I would posit, and I think, Dr. Levy, you'd agree with me, that buprenorphine and other FDA-approved MOUDs are not only indicated, but first-line standard of care.
I would absolutely agree. I would also add another thought. When we treat somebody with buprenorphine, we're not really choosing between buprenorphine and no exposure to opioids, because we know that opioid addiction is a chronic relapsing condition, that very few people with opioid addiction are actually going to go into a spontaneous recovery. And so really what we're choosing between is continued use of illicit opioids like heroin or oxycodone or fentanyl or whatever the young person is using, versus buprenorphine. That's the real choice there. It's not a neutral decision. It's not like, I mean, of course, if we could have the patient be exposed to no opioids at all, that would be preferable, but that's really not on the table if you understand opioid use disorder and the vast majority, like more than 95% of patients.
Yeah, now there might be cases, and I'm jumping ahead, they're hard to detect, I think, in clinical practice, but they do come, and we've all certainly treated some who are in their very early stages of initiation, perhaps experimentation, without daily use, without physiological dependence, without tolerance and withdrawal symptoms. And then the question of whether to iatrogenically introduce opioid dependence through treatment with buprenorphine versus using an antagonist like naltrexone that doesn't introduce tolerance is a reasonable thought. But as you say, in moderate to severe stages, people are already exposed and awash in a bath of opioids, so it's a false dichotomy. Agreed.
And, you know, we actually, the group that you're talking about, these kids who are very early, whose non-medical use of opioids is really sporadic, more than sustained over any period of time. I agree with you entirely. That's the group that I primarily treat. You know, I have a high school age range as the primary population in our substance use disorders program. And we do not put all of those kids who are early initiates, if they don't have withdrawal, if they don't have tolerance, if their history is very short, we do not put them on buprenorphine right away. We may put them on naltrexone, seeing if we can do a short term, but we follow them very, very carefully. We watch what they're doing. We do urine drug testing. We are constantly bringing them back, interviewing them and their parents, just to make sure that things aren't moving on.
And those kids are at very high risk. Remember, it doesn't take tolerance, physiological dependence, and daily use to overdose and die. So the issue and the caution to be very, very closely monitoring them is so important, because it's very easy for them to miscalculate on dose, especially with the potency of fentanyl analogs that are the rule in many major metropolitan areas, certainly where I practice in Baltimore, and I'm sure where you practice in Boston as well.
So great, thank you. I think you're already sort of diving into what the next question was going to be, which, do you have any key tips or clinical pearls when it comes to treating this population for opioid use disorder? And then we'll move on to the alcohol and tobacco as well.
Well, one thing I'd say is we're a little ahead of ourselves talking about the technical aspects of producing pharmacological response. Of course, as we've emphasized, these medicines are first-line standard of care, are life-saving, but getting people to engage in treatment and to take medicines and to think about all of the developmental considerations in addressing youth vulnerability to try to engage them in treatment is really first step before you whip out a prescription pad. The notion of bringing kids into care, of forming relationships with them, of building trust about having their health in interest, engaging their families, all the things that anybody who's on this call, because you're obviously interested in young people, is already doing, whether it's about OUD or other SUDs or other risk behaviors. Those are the places to start. And the pearl, I would say, is engagement, engagement, engagement. And just prescribing a medicine is not the same as getting enduring adherence and getting retention and getting a response over time. And that's the magic and the art of being somebody who works effectively with youth.
So I wonder if I could put in a little plug for the buprenorphine waiver training course. So the American Academy of Addiction Psychiatry has an organization within it called the Prescribers Clinical Support System, or the PCSS. They do a lot of they offer a lot of the waiver training courses that are available, and we offer one specifically for youth. So if you have already waivered for buprenorphine but want to get more youth training, I would really encourage you to see if you can get into one of the youth courses, because I think of the course, there's there's a lot of material that's on the pharmacology of buprenorphine, and that's going to be the same whether you take the youth course or the adult course. But if you're really thinking about tips for how do I engage a 16 or 17-year-old, how do I talk to parents, how do I work with developmentally younger people, I think that it's really all covered very well in there. And it goes well beyond, although it's waiver training for buprenorphine, it's really a very solid course in adolescent addictions. And so if you've got 4 hours and you can find time, and if you're waivered, You might want to do it again because I think the cases are all entirely different and are really worth talking through. And if you're not waivered and you're particularly interested in treating this population, I would say get the pediatric version of the waiver training course. So that's my little plug. And of course, all of those materials are free, and I can help with links and so where folks can find them after the webinar, if that's helpful. And if I was going to give one tip on treating youth, and this is probably not specific to youth, but I would say the biggest mistake in my opinion, is sometimes people want to use the prescription to increase adherence. You know, come to your counseling session. If you come to your counseling session, then I'll give you your prescription. And I think that that's a real mistake. You know, if prescription are not leashes. If the only reason a patient is coming to see you or coming to see a counselor or coming to see is because they're going to get the prescription, that's not going to be sustainable. In our practice, we work very hard to keep our patients on medication for as long as possible, even if they're not following all the rules, right? Even if they didn't give a urine sample this week like they were supposed to.
Wait, young people with addiction not following all the rules? I'm shocked.
So I know it's really shocking, but it's really surprising to me how often prescribers get nervous about that. And they say, well, I don't know, they're not following the rules. I really can't prescribe. And generally speaking, I think our feeling ought to be the opposite. Like, let's at least get them their prescription, so maybe they'll stay on the medications. And by the way, even if they had a relapse and they, you know, and that's why they didn't do their drug test. It's still better for them to get back on the buprenorphine, even if they're not doing it perfectly, to have this sense that we want to keep you on it, to remind them to stay on it. I think that that's really critical. There does come a time where there are certain cases where you have to do some clinical decision making because you're not certain whether somebody's just getting your prescriptions and diverting them so that they can get some other drug or something like that. Those cases, of course, come up. You have to be thoughtful about it. But overwhelmingly, our inclination is really to keep kids on medications, whether or not they're doing all the other things that you've asked them to do.
And we think of the treatment journey as incremental and dimensional, just as you might with diabetes or hypertension, that the gold standard is following all the rules. The gold standard is full abstinence. The gold standard is a full transformative rehabilitative experience. And that's the promised land that we ultimately hope to get to. Unfortunately, we don't always get there. But we recognize that there are partial improvements short of that gold standard that are still associated with considerable improvements in psychosocial function and are to be celebrated and encouraged as an incremental process towards getting there. And just as we think about getting somebody's hemoglobin A1C down from 10 to 8 as progress, but still not ultimately good enough, we can have it both ways. We can say, this is good, this is better, but we have farther to go. And that doesn't mean we would cancel the prescription for insulin because it's not already down to 6.
Right. The worst thing that we can do is lose these patients, right? If we are able to keep connection with them, it's the only way that we have any chance at all of making them better.
Thank you. Yeah, I mean, this is a really great discussion, and it's really driving I think, a very similar message home for the adolescent and youth population that OASAS has been sending overall for addiction treatment. So thank you. I think, I want to make sure we say a little bit about clinical pearls about alcohol and tobacco use disorder as well, not forgetting 2 other really important disorders for which we have medications. So we can save, there's a lot of good questions coming in around opioid use disorder. I think I'm going to save them for the end, just because I bet you some of them might be addressed just in the rest of our conversation anyways. But I'm wondering whether either of you have any clinical pearls or tips you'd like to share for treating alcohol use disorder or tobacco use disorder in this population.
I think of medications as a key component of treating both alcohol and nicotine use disorders across the age span. We're seeing, well, over the past couple of years, we've seen more and more kids coming in with problems with nicotine. As folks on the webinar probably know, rates of traditional tobacco use, of cigarette smoking, have really plummeted over the past 20 years in high school age group. But of course, juuling has reintroduced youth to nicotine, and so we're starting to see those problems again. We are offering kids who are coming in with symptoms of withdrawal and cravings. We offer them medications. We usually start with nicotine replacement. We use a patch. The idea being we're trying to get away from, we're using nicotine, but we're trying to get, instead of the highs and lows, those huge nicotine peaks and troughs that you might get with an inhalational vaping device, that you're getting more of a steady state to try and reduce and relieve the cravings. We have also used bupropion, and occasionally we use varenicline to treat younger people. In our program, we pretty much do it in that order. We find that medication's really helpful. I think it's really important to note that there have been studies that show something like 60% of all high school kids who've used a vaping product in the past 30 days have thought about or made an attempt to quit. So a lot of kids, when they're presenting to any kind of medical setting, anytime they're having a conversation with a healthcare professional, there's a good chance they're already thinking about quitting. So this is really something that you can do to support that. I'll just quickly say about alcohol before turning it back to Dr. Fishman, is that we use primarily naltrexone for alcohol use disorders in youth. There are other treatments we use occasionally, particularly acamprosate, but we don't use them extensively in the younger age groups. It's more naltrexone, and it's really kids who, I would say we use that, we don't use that for every kid who has a history of drinking, of course. We're using it for kids who have the most heavy rates of drinking. We're particularly looking for, the medication seems like it's more effective in patients with a family history of drinking, and there might be some genetic component there. And so they tend to be older adolescents with heavy history of alcohol use, are the ones who are usually selected for a medication trial.
Yeah, I agree. Many of my patients with both nicotine and alcohol problems are young adults. And so when thinking a little bit about that population, I'm perhaps even more aggressive than you described about the full tool chest of medicines. I go right to NRT, but then add bupropion or varenicline. But I will say that adherence is problematic. And I think that the lack of convincing and robust optimism in the research literature is related not to the pharmacological non-efficacy of these medications in younger people, but to the considerable problems we have in engaging them and retaining them and getting them to adhere in a persistent way. And because of that, I think that we've got to move away from when doctors first started to think about NRT and cravings medicine, bupropion and varenicline. We had this notion, as you know, of pick a quit date, start these medicines slightly before, continue them in a discrete way for 12 weeks after the quit date. The quit date is some magical thing at which there will be no cigarette smoking, and then it will be cured 12 weeks later, and then we're done with medicines. And I don't think that that reflects, not only in adults, it no longer reflects, I think, sophisticated practice, but certainly not in youth. I think there's going to be intermittent sampling of cutting down, even with medicines, and although we don't encourage it, patients smoke on patches and it doesn't kill you. It just makes you a little green around the gills and nauseated. Unfortunately, they sometimes make the wrong choice. Well, if I'm feeling nauseated, I guess I'll take the patch off and keep up with the Marlboros. We'd rather they did it the other way around, but either way, there'll be sampling reductions, there'll be sampling quitting, there'll be relapsing, remitting, And if we can keep them engaged, even with intermittent use of medications over time, those incremental bits of positive reinforcement of maybe having a positive experience, of maybe being a little less winded on the days where you smoked less. Oh, I remember that was when I was using the patch. I only used it for a week, then I kind of lost interest, but I'm going to come back to it, and thinking about it as a marathon, not a sprint.
Yeah, I
But
agree.
not expecting that we're going to have these miraculous quit events.
I agree with that entirely, that adherence is challenging, as with anything else, with adolescents, adults as well, but particularly in the adolescent age group. When we're using nicotine replacement, I always use two forms. So we put the patch on, but then give them also either the lozenge or the gum, so that if they have a breakthrough craving, there's something that they can do instead of just grabbing for the cigarette or the vaping device. And then it's also a way that we can sort of monitor them, because if they're using a lot of the breakthrough, then you might want to go up on the patch, right? And you might want to increase the amount of nicotine replacement you're giving them. And if they're really not reporting, if you're really not budging their nicotine use, then we're likely to move on to bupropion pretty quickly after that. And particularly in the older adolescents, I actually think varenicline works very, very well, but we mostly reserve it for older adolescents and young adults.
Yeah, fair enough. And then as for alcohol, I've been using the full tool chest, a lot of extended release naltrexone, but I've also used topiramate, I've used gabapentin. I know that there is a subpopulation of people who divert and misuse gabapentin, but I think mostly not so much, as long as you monitor it. But again, the issue is one of adherence. And unlike buprenorphine, which has its own kind of intrinsic reinforcement for OUD, and people are really quite struck by how helpful it is quite immediately in terms of reducing craving, of relieving withdrawal, of preventing use, even if you sample the blockade and use on top of it. It's not so intuitively apparent with these other medicines for alcohol. If you drink on top of naltrexone, you still get drunk. If you use topiramate or gabapentin or a camprosate, the effect is not only not as large as the MOUDs are, but it is not as immediately apparent. So getting people to stick with it is very hard. And the typical binge pattern of adolescent and young adult drinking is perhaps not as dramatically affected by these medicines as daily drinking in alcohol dependent adults, where the research was initially done. But with all those caveats, still it's the right thing to do, as I think, as a supplemental feature of a full, comprehensive, holistic plan of care, including all the other non-pharmacological rehabilitative or habilitative interventions that you know about. And why not have more tools? Because as good as any of the things we're talking about, whether medicine or behavioral, none of them are perfect. None of them are curative. And so more tools in the tool chest, I think, is always a better thing.
Great, thank you so much for that. I think there is rightfully so much attention on opioid use disorder and the treatment of opioid use disorder, but we can't forget that alcohol and tobacco/nicotine use disorders do cause an enormous amount of burden, and they begin in adolescence. And so
and more deaths, both of them more
right.
deaths than opioid use disorders every year in the US.
Absolutely, and they begin in adolescence, and so any opportunity we can to address those with evidence-based tools as early as possible is something that we want to see happening. I think the last question that I have for you is back to opioid use disorder. Really, what are some of the main challenges that we have to face and we have to address in order to improve access to treatments, including medications for opioid use disorder? But I think a few of the questions that I've gotten sort of do get at that. So I want to start with a few of the questions and comments we have in the chat, and then maybe give you both a chance to respond to that general question. And so one question that I saw in the chat that I thought was really interesting and important, because I've heard it before, is that this idea that the medications for opioid use disorder are simply to prevent overdoses. That's all they do. They don't actually treat the opioid use disorder. So this is not what the comment said, but I've heard it before, that they're only quote unquote harm reduction strategies, and that the treatment is something entirely different. So I'm wondering if you have any thoughts about that idea.
Yeah, I just don't think that that's what the data shows. I mean, these medications actually help to reduce opioid use. I'm going to put another little plug in that recently we started working on an NIH-funded project to develop a fentanyl vaccine. Now that's in very early stages, but it would induce an immune response to prevent fentanyl from crossing the blood-brain barrier. That would be to prevent overdose. Don't really think that that's going to be, treatment per se as a standalone kind of thing, but that could be protection. But buprenorphine has been used, for I think close to 2 decades now in the United States. There's really excellent evidence, and of course, methadone, which works very similarly. It's, we don't have good access for youth, for under 18, it's very hard to get access to methadone, but, all of this stimulation at the opioid receptor centrally is a very good treatment for opioid use disorder, because people use less non-medical or illicit opioids. But they're not only that, but their function increases, they're able to go back to school, back to work, really, everything improves, they get into recovery. So it's not just preventing an overdose, it's really helping them get their lives back on track. And there's actually physiologic reasons, behind that, and that's because the use of opioids, during the phase before treatment is actually recalibrating their central nervous system quite a bit, right? And so when they then try and stop, their system isn't back to baseline; it's in this state of opioid deficit, actually, right? And so the way buprenorphine works is that it's binding to those opioid receptors in the central nervous system, but it's not a perfect fit. And so I really essentially what happens is that it's giving gentle stimulation, but it's not giving those high peaks of, the kind of we see that we might see with illicit opioid use.
And with the jagged peaks and troughs, yeah.
If you want to get kind of technical about it, the thing about buprenorphine is that what it does is it binds the receptor, and it kind of holds it in place, and it's slightly more likely to act as a stimulant at the receptor than as a blockade at the receptor, right? But because of its shape, it can really do either. So sometimes it's going to bind an open receptor and hold it open. Sometimes it's going to bind a closed receptor, unlike the full opioid agonists, which are really always binding it in the open state and holding it open. So so it's giving some gentle stimulation. I think for people who are naive to buprenorphine, they probably would feel a little euphoria with use, but to people who have a lot of opioid experience, don't describe a lot of euphoria with it. It's just really replacing, it's allowing the system to kind of come back into a neutral place, while, whatever healing is going on is happening in the brain.
Yeah, and not only protection against overdose, but think about all of the other behavioral, emotional, psychological hijacking that goes on with the use of street opioids, the time and energy spent in the midst of intoxication, in the midst of procuring supply, in the midst of the narrowing repertoire to have an entirely drug-focused behavioral repertoire, in the midst of recovering from intoxication and withdrawal. With all of those things relieved progressively or partially relieved with improvement, there's more and more reopening of a full life, which is exactly the way we would describe recovery in any other way, more opportunity to rebuild, and that is treatment of OUD.
Great, thank you. So what I'm hearing is that medications for opioid use disorder are treatment, and that they allow further psychosocial treatment or other supports to be more effective, and they improve multiple outcomes, not just overdose death, as important as overdose death is. So another comment that came in that I think is related to some of the challenges that we need to address and overcome as well is just the idea that this idea out there that using medications is not full recovery, is not true recovery, because they're, especially opioid agonist medications like buprenorphine or methadone, they're still using an opioid. And so the way the person who made this comment put it is just, how do we convey a belief in the internal strength of youth and convey hope while using medications that represent a disbelief in opioid users' ability to realize the ideal, as you stated. So just this idea that you're not really achieving full recovery, you're not really achieving the type of recovery that we should ideally aim for if you're using these medications, and specifically how to work with youth around this, or work with some of our providers around this same belief.
It's a very common misconception and prejudice, and we need to talk to patients, we need to talk to families, we need to talk to support workers, we need to talk to policymakers about trying to disabuse people of this false dichotomy. That is to say, endorsing, advocating for, promoting the internal strength and the self-efficacy and the transformative power of youth to make changes in their lives is not incompatible, is in fact fully compatible with the use of all sorts of other tools. We say to people when we ask them to go to 12-step meetings, ask for help, use your tools. If you could have done this all by yourself by snapping your fingers and wishing it to be so, you would have done this long ago. Part of what we're asking people to do is reach out to sources of support and get help. We wouldn't think that the use of medicines for other chronic remitting and relapsing conditions would be a sign of weakness. Self-efficacy and internalized change is compatible with using insulin or antihypertensives. One of the classic lines you hear is, "It's just a crutch." What, that's a criticism? I break my leg, I want a crutch, it's okay. That helps me heal.
Yeah, I couldn't agree more. I think it's really unfortunate when we dissuade young people and their families from using these medications because of thinking that it's not a true recovery if they're using medication. Would it be a true recovery from a depression if we're using antidepressants? Of course it would, because really what recovery is talking about is getting your life back on track, right? And it's getting back into your family, getting back into society, really moving your life forward, becoming a productive member of the community. And if medications can help that, it really doesn't matter to me. And I don't see why it should matter what exactly the medication is doing in the brain if the medications are helping achieve all of those goals, right? And, it's interesting because, some people say, well, naltrexone's maybe okay, but buprenorphine isn't. And, I think that is actually very unfortunate. I'm with Dr. Fishman. If it's a crutch, I'll take it. If we can really get people functioning again, that's what we're really after.
Now, I will say there's another side of the coin, and there are some practitioners who think that all you need is a prescription pad. And we have to be careful not to overpromise. As good as these medicines are, and they have very high effect sizes, we're lucky enough here in the 21st century to have these tools. But let's not overpromise. This is not the penicillin for opioid addiction. These are not curative. We do not have that technology. And to say that just a prescription pad without encouraging people to make internal change and to focus on behavioral change and to change attitudes and to change environmental cues and to improve supports and to develop a broader repertoire of psychosocial function. All of those things go hand in hand. So just as they are not to be dismissed as not real recovery, they shouldn't be overpromised as curative. It takes all of these tools together in a comprehensive, holistic package.
I couldn't agree more. I will put out one thought there, and it's really echoing something I said earlier. We cannot use medications to engage people in other kinds of activities. They have to be engaged because they see the utility of them. So we can't, or we shouldn't. I don't think it's a good idea to say to patients, well, I'll start you on medication as soon as you show up to your group therapy appointments.
If you live that long.
Yeah, exactly. I mean, that, that really just doesn't work. And I think that Lisa Marsh has a study with her group showing that, interestingly, she had different designs. So some people, some young people who were put on buprenorphine in one of her more recent trials had the option of, going to counseling when they wanted, and some of them had to go on this very strict regime, and the people, or they would be, or they wouldn't get their medications, and the people in the latter group didn't do well, right? Because we have to be engaging youth. So, we have to be working with them. They're not always going to follow all the rules. They're not always going to go to every appointment that you want them to. And that's really just part of what it is to treat this group. So yes, we want them to do all of it, and we just need to stick with them. And, I've treated some kids for more than 15 years. They're adults now. I have actually started kids when they were 15, 16 years old who are now parents and employed. And, I've actually seen people go through, their entire adolescent and into their adulthood on these treatments. And I know that really things really do change over time. And so, really working with them and following that developmental trajectory along with them and keeping them engaged is really the key. So it's not just medications, it's not just counseling, it's some whole package that they really need.
I see in the chat room an important question that I think it's worth talking about. You don't control alcoholism by using alcohol. Opioid medication for opioid use does not equate with insulin for diabetes. And in terms of the analogy to diabetes, fair enough. It's an analogy. It is imperfect. It is not to say that they are exactly the same. It's an imperfect metaphor, but it is illustrative. And remember, the reason, I imagine, I don't want to put words in the questioner's mouth, the reason we don't use alcohol to treat alcoholism is because it's a short-acting intoxicant that when people use it, have these peaks and valleys and experiences of intoxication, non-intoxication, withdrawal, and impairment. Over time, listen, if we had a long-acting partial agonist alcohol substitute, it would be an empiric question as to whether that would be helpful. I don't know. What we have with the partial agonist buprenorphine is 30 years of replicated research in almost every population that you can think of to show enduring benefit. And it didn't have to be that way. It's not a philosophical question. It's that the data came out that way. As close as I can go, and it's very old literature, but as close as I can go to the agonist substitution in alcohol use disorder is that people have done trials of long-acting benzos as similar, not perfect, GABA agonists for alcohol. Not that it was a terrible idea, but the results were negative. People got worse, not better. They were more intoxicated, disinhibited, and impaired over time, and didn't reduce their use of alcohol. So go figure. But it's a question of when we see that with these medicines, opioid use does reduce. Oh, by the way, a more modern analogy is the use of dronabinol, a synthetic THC agonist for the treatment of cannabis use disorder. Good idea, bad idea? I don't know. Let's do some studies. Well, we did. And although the patients like it, they don't use less cannabis. Okay, doesn't work. But that is contrary to the result that we have with opioid use disorder, where they do use less and they do have greater rates of abstinence. Not everybody has full abstinence, but many do.
Great. So thank you so much for addressing that question. And there are other questions in the chat. We have 5 minutes left, so we're not going to get to some of them. You did briefly, there are some questions about cannabis use disorder. We don't have time to go into it, and there are no FDA-approved medications for that disorder anyways. There's some questions about benzodiazepine use disorder. We don't have time. So we kind of knew we wouldn't get to every single question, but I still think we had a really great opportunity for some discussion and Q&A. I'm just wondering in our last few minutes, Dr. Lee, Dr. Fishman, do you have any final words, points of wisdom, things that you wish you had gotten to say but didn't come up before we wrap up?
I guess I would just end up by thanking you for organizing this and thanking everybody who got on for taking the hour to think through these pieces. Addiction psychiatry, addiction medicine are now recognized as their own branch of medicine, which I really think will help us bring a lot of these issues to light. But just the fact that you've got all of these people who want to come on, who really want to talk about and think about, what could I be doing in my profession, in my area, in my lane, so to speak, to be treating substance use disorders in young people. It's really encouraging and exciting to see the amount of enthusiasm there was and the number of questions that really come up, that people really want to think this through. And so really, I'm delighted to be a part of it. And I think it really speaks so well to the kinds of things that people are thinking about these days, and really it's going to help us move the needle.
Yeah, it's great that there are so many of you who are here because you're interested in helping young people and their families, and there aren't enough of us. There aren't enough of you. And to wrestle with these issues, to think about conveying the message to young people and their families that these are important issues, that we want to talk to you about the health consequences of the use of substances, and most importantly, that we respect you for an honest dialogue, that we want to engage you, and that we want to convey optimism that you can get better. Despite whatever tools we have, whatever technology, whatever fancy pants new medicines we might invent, at the end of the day, what we do the best is therapeutic optimism, giving people hope that they can turn their lives around and get better. So thanks for being interested in that.
Thank you so much. This was a great conversation, and I really appreciate you both taking the time to enlighten us and to clarify the general treatment philosophies that we use when approaching youth and adolescent substance use disorders. So I just want to remind everyone that we have 2 more webinars with Dr. Fishman and Dr. Levy separately this time planned for you. So please feel free to register for those. They'll also be recorded if you aren't able to make them live. Maria, do you have any final announcements or words for us before we leave you all today?
Just to say thank you to you, Dr. Manseau, for leading the discussion, Dr. Fishman and Dr. Levy. It's wonderful to have colleagues across the country to call on and that are willing to lend their expertise to this important dialogue. So we look forward to having everybody join us next week for the next in the series, where Dr. Levy will talk about pediatrics and primary care when working with youth and young adults with substance use disorders. Thank you.